back, 2 years back, I remember giving a talk in Mumbai where I said that initial high titers may not be important, but I have taken back my words that initial high titers do matter. That's why I said that be wary, see how the titers are behaving, and in the post-op, don't let the titers rise, because those with initial high titers probably have a more immune reactive system and they may be more prone for developing AMR. And 1:64 titer, I take it as an indication for plasmapheresis even if the LFTs are normal.
The last comment.
Well, yes, splenectomy has been done. I've not done a splenectomy for ABI but it's well reported that in emergency situations when you are unable to give rituximab, or they have, especially the Japanese are very fond of doing.
And what we saw that there's a doubling or a rise in the titer post-operative also. So we decided to wait for another 3 weeks. Like Dr. Shaleen said that we cannot underestimate the rituximab. We have to give the right dosage. But yes, waiting for the right time. So what we have seen that waiting for 3 weeks has given a stability to the titers even in the post-op. And incidence of doing plasmapheresis or repeated biopsy after the transplant has significantly come down in our series. That's what I would say. Thank you.
Of small for size grafts during benching. I would like to present a particular case. So we had a 47-year-old male patient, HBV, HDV, CLD with HCC, with a MELD sodium of 25, child C, whose only prospective donor was his 30-year-old niece, who on a triple phase CT had a left-sided gallbladder with a total liver volume of 1,115, for which we decided to take segment 6, 7, that is a posterior sector graft, because of the portal vein anomalies that were associated. As you can see the imaging, this is the portal venous imaging and the artery, and this is the venous image along with the MRCP. So the issues in this case was, this was a left-sided gallbladder with portal vein anomalies, and in this we had a low GRWR for this patient to begin with. As you can see on the CT image, so we had planned a posterior sector graft which was segment 6 and 7, and as you can see there is a large segment 7 pedicle which comes from the anterior division of the portal vein. So already we had a low GRWR to begin with, and by deducting the approximate 27% of the segment 7 crossover, it gave us a GRWR of 0.599 or 0.6. With all due risk explained to the patient, we decided to go ahead with the transplant. These were the intraoperative images. We had a left-sided gallbladder, as you can see. We went ahead with the porta dissection. We looped the posterior portal vein, the posterior artery, right hepatic artery, and the posterior bile duct. We got a very good line of demarcation on the undersurface of the liver, but on the upper surface of the liver, as you can see, where there is a segment 7 crossover pedicle, the line was not as good. On transection, we had a large segment 7 crossover pedicle which gave a large area of.
Has to be well versed with their own technique, and they should do it every time similar way, and until the biliary complications or outcomes are reduced or outcomes are better, they should not stop. They should keep on experimenting with their own techniques. So we published this paper way back in 2016, targeting Achilles heel of liver transplant, as we know that biliary complications are Achilles heel, 25 to 30%. This was our first paper, and in that paper we published our biliary complications to about 4%. But now with the long-term follow-up, they have gone up to about 6.5% approximately, including all leaks and strictures, which is one of the world's lowest biliary complication rate. So to describe my technique, I think, as I told you, that principles matter more than actual hand movements. So the first principle is donor duct division, where we should preserve the vascularity of the donor bile duct. We should be as precise as possible with the donor bile duct, keep a lot of tissue around it, keep the vascular structures around it. I think this is very important. Too much dissection, like in minimally invasive donor hepatectomy or robotic donor hepatectomy, I think that might lead to increase in biliary complications. We should stick to the principles of preserving a tissue of coin or wall of tissue around the bile duct. That is very, very important. Second part of it is recipient duct. We many times ignore the recipient duct, but that duct has to be anastomosed to the donor duct. I think keeping a lot of tissue around the recipient duct and the single most factor of high division of recipient bile duct. Divide it as high as possible. Because if we are very low on the bile duct of the recipient, there are only 3 or 4 axial blood vessels which supply the bile duct. As we go higher, there is a complete plexus. And we have seen that high division leads to a lot of bleeding from the bile duct end, and that is very, very important.